Hello and welcome to today's webinar for mental health professionals, Enhancing Treatment Impact and the Therapeutic Alliance in Remote Therapy, featuring Dr. Cherie Charvet. I would like to introduce Dr. Charvet. Dr. Charvet is a clinical psychologist and the Associate Director for Training at Palo Alto University Center for M2 Health, California. She also serves as the Chief Clinical Officer at Elios Health, a startup company in the digital healthcare space. Dr. Charvet has previously worked at Stanford University Eating Disorders Research Program, where she received research funding to conduct intervention studies on family and parent-based interventions. Dr. Charvet's clinical and research interests include eating disorders from infancy through the life cycle, online interventions, incorporating technology in mental health care, and clinical training. She co-authored the book, Parents with Eating Disorders, a Treatment Guide, published by Routledge. There will now be a brief moment of silence while I pass the presenter role to our presenter. You should be able to share your screen, Dr. Charvet.
Can you see my screen now?
Yes, you're all set.
Okay. Oh, okay. Okay. Thank you so much, Vicky, for the introduction, and thanks to everyone joining this webinar and watching it from home. The focus of the webinar is enhancing treatment impact and the therapeutic alliance in remote therapy, which is part of our current daily life and our reality as clinicians. I'm going to talk about different ways in which we can utilize the existing remote therapy and online assessment tools to understand what's going on with our clients, understand them a bit more, their experience, and support them while improving the therapeutic relationship, which we know is fundamental for increasing efficacy of the treatment. In terms of disclosures, these are my disclosures. Let's start. So as clinicians, we often encourage our clients to assess reality, check the facts, and evaluate their options within the existing opportunities and possibilities. The whole mental health field needed to do the same thing about 3 months ago, at the beginning of March 2020, when it was clear that we will not be able to see our clients face to face, and that for some of them, or even for some of the clinicians, in-person treatment creates a substantial health risk. So we needed to adapt already and utilize tools that already existed there, fortunately. Pandemic has dramatically changed the landscape of digital therapy and therapy in general, making telehealth a staple in the therapist toolkit. It would be unethical for you to not be able to provide this to clients, especially to those who can be managed remotely. And what we've learned is that there is a gap between clinicians and client expectations. Us therapists have been primarily trained in assessing and treating clients in face-to-face settings. Our schools are usually face-to-face. We see clients face-to-face. Many practicum programs that contacted me through the past couple of months have told me about their struggles in adapting to the new reality, although the vast majority of programs has adapted well. But training in digital therapy and remote treatment was not part of the standard curriculum. But in real life, where are our clients? Individuals are typically in close proximity to their phones. If you look right now, your mobile phone is probably within arm's reach. We use it for work, for interpersonal connection, for searching information, that is important for us, including health information and for recording information that we consider important. And our clients, to be honest, have long not understood why we ask them to postpone sharing information they deem as important until the next session. They haven't read the books and they don't know that our models are based on one session a week, where we meet face-to-face and we can assess the clients at all different levels. Here, the new reality has changed the tools that we'll need to use. And just like we encourage our clients to adapt, we need to do so ourselves. So even long before the pandemic, clients have expected technology to be integrated in their healthcare or in their mental health care. In their regular healthcare, they have long been encouraged to email their nurse, fax or text or scan any of their imaging results, etc. There have been more than 3,000 health apps that are currently available, mostly for free, and many of them are related to mental health. In a study from 2016, about 76% of respondents said that they will be interested in using their phone for self-management and self-monitoring of mental health. And studies have found that greater health problems are associated with greater email use with providers, with nurses, and with healthcare organizations. And now with social distancing norms, technology can provide us an opportunity for distance socializing, continuity and integration of care. So that was on the client's end. The most recent study on practitioners' barrier to practice with digital tool was published in 2016. I know many of my colleagues are now collecting data on therapists' assumptions and expectations currently post-COVID. But before COVID, clinicians talked about lack of experience or training in digital therapy, poor access to technology, a preference to meeting face-to-face. Many of them expressed no need, no interest. I'm sure this has changed dramatically. Many of them have also indicated there is no reimbursement from health insurance, and there were substantial health institutions and organizations putting restrictions on communications to office visits only. This, fortunately, has changed and allow us to expand our toolkit and really be mindful of the tools that we use, how we use them, and how we can implement them to improve our clients' well-being. As I said, the question is whether this is social distancing or an opportunity for distance socializing. This is a screenshot from the Seder dinner at my home with 4 different calls at the same time from people all around the world. And I thought it was a nice reflection to what I assume many of our clients are feeling, that they need us now more than ever before. There have been some financial concerns affecting millions of people, lost jobs, economies changing, stock market going down, many reporting food insecurity, increased stress and trauma at home. We all know that the calls for partner violence and family violence, domestic violence centers have increased dramatically. Many patients lack access to healthy coping mechanisms. They cannot meet friends, or they need to limit the number of friends with whom they socialize. Many clients report exacerbation of existing psychopathological symptoms. There are also negative media messages about productivity and self-improvement. You have to use this time in order to improve yourself, learn a new skill, learn a new language, lose 10 pounds, etc. this all exacerbates existing psychological symptoms and adds additional perfectionistic, unrealistic expectations to most individuals. And of course, there is greater use of social media, which we know is detrimental for mental health and increased social comparison. So how do we help our clients given this context, this reality that is not going to change soon? Digital tools can make therapy more efficient, effective, and fun. They can help with communication and scheduling the next sessions. They can help with assessment and monitoring, as I'll show you in a number of tools that I'm using. They can help with psychoeducation, providing support between sessions. Something that I have discovered is substantially important these days and has become more and more prevalent that clients feel that the 1 week, weekly or bi-weekly sessions are not satisfactory and they need more interactions in order to maintain the recovery and continue the momentum of treatment effects. Online therapy can also help us address important issues that may not be the therapist's major focus or area of expertise. For instance, we can prescribe apps for sleep, exercise, weight management, etc. As you all learned, now treatment is more flexible, so we can schedule meetings at different times when we can have video conferencing instead of a client needing to drive to our clinic. And it can provide continuity and integration of care, teletherapy when the patient cannot come in, just like they are. The problem is these days. So in May, May 1st, I tweeted on Twitter, feeling Zoom fatigue. It makes sense, stemming from my experience as a therapist and as someone involved in many studies and with the research meetings, and what I experience, I assume, is common to a lot of people, and there has been some new research indicating at least some of these experiences. Sedentary lifestyle is definitely not helpful, neither for us nor for our therapy patients. Even if you sit in a clinic, but you need to walk to your car or just even walk to the waiting room and greet your client, we are not able to do these activities, and we need to be mindful about prescribing them and thinking about when our clients are physically active. Screen time and blue light exposure exceed medical recommendations. And of course, there is no downtime between online meetings and home activities. I, like many others, work right now from my home. And when I open the door and go outside to the common areas, then I need to deal with my other roles, a parent, a spouse, a daughter, a friend, etc., a homeowner. And there is no downtime. So now I even more appreciate the 7-minute drive that I had between work and home. And the idea is really to talk with our clients about scheduling breaks, stretches. I do that almost at every session. And I also have done it in webinars that I've given that were longer than an hour, where participants practice the mindfulness and stretches. Try and change the scenery of your home, take the call from a different place, see whether what's important for you is the background or maybe what you can look at during the session. And of course, schedule time away from your computer or your phone. Before I delve into the tools, I'd like to discuss the core principles. So of course, always follow your usual ethical standards. Be mindful of privacy, where digital information goes, where it's stored. Ask your clients about their experience in groups that I facilitate. Every couple of sessions, we take some time to reevaluate how people are feeling this week regarding being in treatment remotely. What are the current challenges, and reorient people back to the program and to the guidelines of working together. And of course, explore and have fun. That's a core principle in everything that we do. Digital technology can enhance self-monitoring and assessment and help us really understand what's going on with our clients. All interventions are based on data, whether you're a couple therapist, individual therapist, group therapist, integrating many of the different hats in your role, providing psychodynamic oriented treatments or CBT or other time-limited interventions. You need to collect data. And technology can help you understand whether your client binges and purges 3 times a week or 3 times in the past 6 months. That's different. That's a different treatment. And whether the couple with whom you're working have a conflict, heated conflict every 2 days, 3 times a day, or once every blue moon. So that's very important in order to understand how to plan your intervention. When you use technology remotely, you get to be with your client during the week, collect data. They can send you information using really sophisticated apps with all the bells and whistles, but also using very simple apps and solutions as I'll describe soon. They can use visual information, they can record in the moment and let you know later what exactly were the triggers and the context for a certain behavior, thought, or urge. Self-monitoring and assessment can be very simple. Many of my clients use the Notes app. They don't need a sophisticated app, and they don't want to download another thing on their phones. So they can, here you see different versions. They can email me. They can write everything on the Notes app and then read it out loud during the session, and they can also text me. To me, that's okay. As I said, practice according to your own values and principles and ethical standards. The key issue, I think, these days is how to provide support remotely and make sure the treatment is still effective and you lead your clients to where they want to be using the tools that you developed while training as an in-person therapist. American Psychological Association's definition of telehealth is the provision of psychological services using telecommunication technologies, which can be synchronous in real time, that's web conferencing, or asynchronous, time delayed, like texting, and email correspondence, which is technically psychology, telepsychology by this definition. I'm a great believer in email and text messaging. I think they complement clinical practice, help you become closer to your client, understand them better, help the client understand or experience you more connected to them. They can streamline communication, provide greater connection. We can help with shared decision-making in the moment for some decisions that can't wait until the next session. Texting and email can help the client develop better self-management, and therefore they increase the therapeutic alliance. They can increase provider efficiency when we start the next session knowing what happened to the client in the past week. And it's also an opportunity for the client to express emotionally charged content that they may be to feel too guilty, ashamed, or embarrassed to tell us while in treatment face-to-face or while web conferencing. I like to let my clients know at the outset of treatment that I'm very happy that we're starting to work together, and I believe I can help you with the issues that you have raised. But I also want to let you know that this treatment is effective when important issues are discussed in our meeting. I'm unable to provide response to phone calls and messages immediately. I will do my best to respond within 24 hours, but if you are concerned for your safety, you should go to the nearest ER or call 911. This way, I let my clients know that email and text messaging is welcome, but that I won't be responsive and that it shouldn't be used for immediate concerns. Let's talk about best practices that should be assessed, and I believe that once these rules are clarified up front, they can help improve the therapeutic alliance and connection and treatment effects. But if you don't think about them beforehand, things might get complicated. You should educate your client about privacy and confidentiality of correspondence, clarify expectations for availability, response time, urgency, just as I said before. Save a copy of text in the client's permanent health record. That's why I ask people to email me and not to text me. Add text and email correspondence to your informed consent. And I also recommend creating semi-structured text for challenging situations. And you can consult with peers and supervisors on different texts that you want to incorporate. The tricky thing is what happens when you need to respond to text and email messages that are quite complex, complicated, or conflictual. I recommend, in order to really maintain momentum of treatment, be succinct, reiterate information and skills you know your client has already mastered. For instance, if they're using diaphragmatic breathing, email is not the right time to teach them mastery visualization. Okay. Maintain a professional tone, of course. Avoid criticizing a third party, as these texts tend to be screenshotted and sent to another person. Keep a positive emotional tone when possible. Our text and email correspondence are often slightly skewed to the positive side since we lack the voice, nuances, and body posture, and all other non-verbal cues of empathy. Then make sure that your tone doesn't come off as too direct, too critical, or too rigid. Reply from an email account that is associated with your professional role, and of course, avoid writing unnecessary information, as these texts can be read by other people. I know that many therapists are worried about personal boundaries. We've all experienced this in the past couple of months, where the times and location of therapy is, and our work in general is undefined. So here are some guidelines and some ideas. We know that email and text communication might require additional expenditure of clinical time, and it's your decision, of course, if you're going to implement it in your practice or not. I believe that boundaries may be crossed when the ground rules for using text communications are not articulated upfront. My experience and also research findings have been that the number of text and email messages reduces over time. That's important to note. So even if you feel like your client is bombarding you with questions and with self-monitoring sheets and with other information, this usually is characteristic of the beginning of treatment, and then it kind of evens out. And again, always practice in concert with your personal values and preferences. If emailing is not for you, then it's not for you. But then you'll need to think of another way in which you communicate with your clients these days. One really nice study that I want to share was text-based maintenance following hospital discharge. Researchers in Germany randomized participants that were patients in residential treatment to a group that would be corresponding with their old therapist post-discharge, and control group. Patients were asked to send just one text message to their therapist once a week for 16 weeks post-discharge. Their therapist responded in a text that was adapted to the patient's message, but only one text. So one text from the client, one text back from the therapist for 4 months. And not surprisingly, the patients receiving texts had much less eating disorder symptoms and better functioning than controls. It's really important to remember that most of us, I assume, would love to send our clients only one text a week for a couple of months following discharge or treatment termination if we knew that this would lead to improved outcomes. So this is something to remember, that while termination is complete, you can continue monitoring your clients and helping with avoiding relapse and not letting a sleep turn into a slide during the few months following termination. Okay, let's move to teletherapy. Benefits for clients are clear when they cannot come up to the clinic due to COVID-19, or they live in an area with few mental health resources, or they need a specific language like sign language that only you can use. Maybe they have PTSD or agoraphobia, and teletherapy would be the first step. And maybe they're traveling or moving to another place where the current provider is still licensed. Remember that we are prohibited to practice across state lines. There have been some relaxation in the regulations recently, but in general, that's the case. For clinicians as well, teletherapy provides an opportunity for flexible scheduling, better response for consumer demand and convenience, especially during COVID, when many ex-clients need some additional support and reach out for help, either because they have some issues or because family members have advised them to seek counseling. You can fill missed sessions or business opportunities, and there is growing empirical evidence as to its effectiveness and cost benefit. It's important to note that research suggests that client ratings of therapeutic alliance when working with the clinicians that incorporates internet-based interventions are high, and ratings of alliance and therapeutic alliance are equivalent to ratings of face-to-face therapy. So your clients are really receiving or having an opportunity to receive really great high-quality care when they meet you when they meet you remotely, just like they would receive when you're meeting face-to-face. Here are some of the practicalities of teleconferencing. Most of them audience here has mastered already, but I would highlight them in how they affect treatment impact and the therapeutic relationships. I'm sure by now everyone has reviewed privacy and informed consent issues with their clients. Everyone knows the local licensing requirements. Most of you hopefully are using encrypted services. Here I listed a few, but I know there are many more, and every time I check the services, there are a few new more that are HIPAA compliant. It's always good to reassess with your client their location, bandwidth, connection issues. They need to make sure that Wi-Fi is not used at home, or they would use their data services on their cell phone. Location, if they are at home and they speak about a family member, maybe taking the call from the car would be better, or from a park, any place where they would have privacy. Every session, it's important to ensure client safety, assess for self-harm, for suicidal ideation more often than you would face-to-face. And also know the local police to call in case of emergency, and get at least one contact information of an emergency contact. You should decide with your client what happens if the telehealth meeting ends abruptly. Do you continue on the phone? Do you try to reconnect again with no video, or you just reschedule? And of course, plan your office background attire and background noises and internet speed, as you've already done probably by now. For virtual group treatments, which are treatments that are now even in higher demand than ever before, because people just crave the human connection, it's important to define a virtual waiting room and admit participants sequentially only after verifying their location and whether their emergency contact information remain the same. Mandate that video and audio be turned on. And we see a lot with teen client population that they're used at school in the Zoom meetings and virtual learning at school to be where everyone is muted and their video is turned off. They generalize this experience to virtual group treatment, and then it's important to educate them that in this specific session and context, video and audio are turned on. Ask them to correct the name that's appearing on their video, mostly delete last name and any identifying information. Of course, that first name is not HIPAA compliant, or it is HIPAA compliant, it's not a breach of HIPAA. I work a lot with eating disorder populations. I offer clients to hide their videos so they won't be too distracted by how they feel. I know that this happens when a client starts like playing with her hair or checking her makeup, or then I offer them maybe hide your video and focus on the session. By the way, I offer you to do the same. Just like we would do in a regular face-to-face session, we typically don't see ourselves and reassess how we look. You can send handouts prior to the session or share screen to visualize the content. And if possible, have another colleague on call so they could contact participants who logged out of the meeting, especially when there is concern about self-harm or other risks. In a couple of months, there will be some relaxation in social distancing regulations, and many trainees have asked me, should my clinic remain virtual post-COVID? My assumption is that we're all social creatures and we need and crave and cannot function without the human face-to-face connection. I assume that the need will likely be bigger than ever before once this emergency situation is resolved. But however, your clients and you may feel that commuting to treatment is a nuisance and a huge bother, and maybe you want to continue meeting remotely. I recommend using a hybrid model where there are remote sessions and in-person face-to-face meetings, and they are integrated within the same context of treatment. And this would help facilitate, especially as we near the winter and there may be a second wave, and there may be also local bursts of COVID in different locations. There then you can utilize both of the options and really check with your client what works best for them. So I want to use a quick case example for how technology could be used to facilitate greater impact of treatment. This is a case report that is now under review in a peer-reviewed journal. A client that has recently graduated from a liberal arts college started the new adult job, air quotes. He has felt concerned about his future, unsure which career path to choose. He received a promotion at work and was very anxious about it and had hard time concentrating. The therapist sent online assessments for PHQ-9 for depression and GAD-7 for anxiety. And when the client sent them back, it was clear that his depression and anxiety were both in the very severe range. So this is a really great use of technology. You can't see the client face to face, but you can send them some tools that are standardized and can be assessed remotely. And since insurance covered only 12 sessions, the treatment of choice was CBT, due to other reasons, of course, as well. So we use in this case some technology to record the session and analyze some key metrics and see how they changed. The therapist realized that she was talking too little. The patient was very agitated and concerned about many things in their life. And in supervision, the therapist saw that the client was speaking 80% of the time, and well, if she was speaking only 20%, she didn't have the same opportunity to provide skills, psychoeducation, explain the CBT formulation and the ABC model, etc. We also learned that the speech rate of both the patient and the therapist was not aligned, not in sync. The client was speaking very slowly. The therapist was speaking very fast, potentially because she thought maybe that it would be more difficult for her to drill in some of the information that she wanted. Therefore, she took those metrics into heart and consulted with her peers about it, and how to really utilize the treatment well, giving the information that technology provided, and brought it up with the client. And then, as you see, throughout the end of the session, the end of treatments, patient and therapist speak ratio was more balanced, and they were more in sync in terms of the way that they spoke. Clients spoke much slower, and the therapist spoke, the clients spoke much faster, and the therapist spoke much slower. They were more in sync. The therapist also asked the client to complete the GAD-7 PHQ-9 every week so that she could assess the effects of treatment. As you see, when you collect the data remotely, and really PHQ-9 and GAD-7 are so quick and simple, your client can just complete their self-assessment. That like there are like zillion online programs and online pages for that, and they can just screenshot the result and you will record it, or you can use more sophisticated services for collecting data. And you can see that after session 3, there was an increase at session 4, and then when the therapist asked about it and was able to address the concerns, then the client reported some decrease in symptoms until they were not in the clinical range for any of the problems, not for anxiety nor for depression. Okay, another point that we need to incorporate in digital therapy is to assess our how social media is affecting our clients. Therapists may be under assessing or not assessing at all in a study where individuals who received eating disorder treatment in a group setting were studies. They reported having between 10 to 19 Facebook friends from treatment, spending up to 30 minutes per day interacting on Facebook alone with individuals from treatment or eating disorder related organizations. And those with greater comparison to treatment peers on Facebook also experienced greater eating disorder psychopathology and eating disorder related impairment. Of course, this is a correlational finding. Therefore, it could also be that those with greater eating disorder psychopathology compared more to friends on Facebook. But only a fifth reported that their therapist asked them about the impact of Facebook on their symptoms. So I encourage everyone to continue asking your clients and interviewing them about different effects of different stimuli and different sources, including social media. Online support groups experience now high demand since people are craving greater interpersonal touch. If you recommend online groups, know which group you're recommending and monitor the client's use and experience of the group. In general principle, we recommend that you recommend your client and use yourself built-in apps for monitoring screen time and activity. Consider incorporating more authenticity and real connections, synchrony between the client's actual values and how they behave online. I ask, not to say beg, my clients and my kids not to use social media after 9 p.m. Both groups have reported this results in better mental health. And of course, you can always mute or unfollow triggering accounts. Okay, so to summarize, how can you use technology to enhance treatment impact and the therapeutic alliance in remote therapy? There are few challenges that arise with technology, but technology can also help us solve, or we should be mindful of. For Zoom fatigue, which is a real issue, we recommend scheduling breaks, stretches, using a hybrid model to meet in person when possible. We know that behavioral activation and pleasurable activities are harder to come by these days, so you really need to be mindful with your clients and make sure they follow through and complete the behavioral experiments and the pleasurable activities that you plan. If there's family around, consider integrating them in the therapeutic process. They can be a huge resource and helpful in recovery. Reinforce the client's existing resources, help them brainstorm and troubleshoot any difficult issues that they have right now, given the current context. And I would prescribe support groups, social distancing activities, volunteering these times, etc. And as I mentioned a few times throughout this talk, maintain your professionalism and common sense. Confidentiality might be compromised. Expectations should be clarified upfront. Digital services should be part of the informed consent. Your professional values and preferences should be the way should decide how you function and how you navigate through the existing opportunities and options for your clients, and encourage your clients to foster meaningful relationships beyond the treatment relationship, remotely and face-to-face when possible. Okay, thank you so much for joining this talk. I hope you find it helpful. I'm available for additional conversations in my email, via my email, shiri@ilios.health. I wanted, before we finish, to inform you of some interesting resources. Of course, you have many opportunities for webinar in diverse options and diverse subjects on the ADAA website at adaa.org. APAA has provided some guidelines for using telehealth during the COVID-19 pandemic by state. It has prepared guidelines already in 2013, and there are also many other programs and options that are available. Thank you so much for listening to this talk. I hope you find it helpful, and continue spreading good in the world with your clients, helping them meet themselves where they need to be, where they want to be, and help them recover. Thank you.
Thank you very much, Dr. Sharvit. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, and much more. We would also like to invite you to check out more ADAA on-demand webinars by visiting www.adaa.org. On behalf of ADAA and our presenter, we thank you for joining us today.